Okay, our next presenter is Dr. Rene Loewenson.
Is this working? I'm very happy actually to have the opportunity to talk to you, and I was asked to give a little bit of an overview of a new policy discussion which is on the table globally but also within Zimbabwe on what is called universal health coverage. And I don't know if this term is familiar to you. Can I just get a sense? I mean, firstly, how many of you would say that you work within the health sector or in a field that has some relationship to the health sector? Could you just put your hand up so I get a sense of how many of you? Okay, and how many of you have heard the term universal health coverage? Okay, so more people have heard the term than actually work with health sector, so that's quite a good thing. The health sector is a kind of a peculiar sector, and health insurance and health financing and health delivery and so on and so forth has its own particular value systems and rules and procedural issues that need to apply, that are to do with matters that are not just to do with demographics, but to do with public health effectiveness, to do with financial effectiveness, and so on and so forth. So I'm going to try and give you quite a quick overview of some of the issues we are facing in trying to address universal health coverage, and generally globally, but also within Zimbabwe, and then try to look at what does it imply for some of the way we address our challenges here in Zimbabwe, and maybe for some of the different kind of sectors that are engaging with working with health in Zimbabwe. I'm from Training and Research Support Center. It's a research center that's based in Harare, but we work internationally, both within Africa and globally. We're actually doing some work now that is also doing what we call reverse innovation, giving advice to high-income countries from experience in low and middle-income countries. So I think we're in a scenario now where nobody has all the answers. And there's a lot of learning globally from work that's going on in the South. And some of what I'm going to present has been developed together with people in the Ministry of Health, with Zekaru, with Atchison, who's one of your members, and with other colleagues from university, etc. But I need to say that what I'm saying to you, except where I explicitly say it's a policy position, I'm saying to you as from task. So please don't run away and say the Ministry of Health says this, so that you're clear about what I'm presenting. So basically what I'm going to work through is what is universal health coverage, very quickly. What are the kind of policy commitments that have been made already to achieve it within Zimbabwe and globally? What are the issues that we are having to address to deliver on universal health coverage? What are the kind of policy principles and options we have available to us to address some of the challenges? And then what sort of opportunities are there for innovation and learning? And there's a lot in the latter category, but because of time I'll probably just flag one or two issues. So to kick off, and for those who haven't heard the term, universal health coverage basically refers to ensuring that everybody has access and coverage, meaning that they not only get to, but that they are effectively covered by the health services that they need of a sufficient quality at the time that they need it, in a way that does not cause them any financial hardship, in a way that does not impoverish them. And when we talk about health services, we're talking about preventive, promotive, curative, and rehabilitative. So we're not simply talking about when you fall ill and you go and use the service to get better. We are also talking about the things that stop you from falling ill, whether it's malaria, mosquito spraying, or vaccination, or a whole range of things that we do around diet, etc., exercise, that are to do with stopping you from falling ill in the first place. Fluoridation of water, treatment of water supplies, and so on. And some of the key issues around it means that in any discussion of universal health coverage, we need to take into account equity, because we have existing inequalities in who accesses services. So we need to make sure that if everybody is pulled to a level of access, that we overcome those inequalities, not all of which are determined by the health sector. Some of them come from other factors in the economy, in society, and so on, gender inequalities and other social inequalities. Secondly, we need to make sure that when you use the service, you get a service that is actually effective. You get a quality of service. There's no point in going there and then being a number that doesn't actually get effective coverage. And then thirdly, this point of what we say financial protection, which is very important for universal health coverage, is that any money that you have to spend for healthcare should not impoverish you, should not push you below the poverty line. And we tend to think about only the poorest of the poor, but some of the studies that have been done in East and Southern Africa show that with very high commercial costs of healthcare, even people in the second, third, and sometimes even more middle class groups in those wealthy areas may be pushed into poverty as a result of health spending if they are having to spend a huge amount for their medical care. So it doesn't necessarily mean that this is just targeting the poorest of the poor. It means making sure that you do not get pushed into poverty as a result of health spending. The point about universal health coverage is it's not a set of policy prescriptions that says you must do A, B, and C. It's a set of policy directions that says how you are going to move, that gives you a challenge to move in those directions. But every country has their own choice about how they are going to achieve it. And so I just want to make clear that I'm not going to leave you with a recipe book. I'm going to be elaborating the policy principles that we should be thinking about in trying to move towards universal health coverage. So universal health coverage has been an issue that's been on the agenda for a long time in various ways. Talking about primary health care, health for all since the 1970s and the World Health Constitution, the World Health Organization Constitution. It was given new life when the UN in 2012 passed a resolution that our country, Zimbabwe, was signatory, together with many of the other countries globally, all the other countries globally, that countries would move towards affordable universal health care. It didn't say it would happen by 2020, by 2030, it said we will all move towards affordable universal health care. That was then reinforced in the 2015 Sustainable Development Goals, that again we were signatory to, that actually said that by 2030 we should be delivering on universal health care. Okay, on universal health coverage. So we do have a target, which is Sustainable Development Goal 3, that elaborates that we should achieve universal health coverage by 2030. So there is something that we've signed up to that the global community is going to be monitoring, that we should also be moving towards. But it is contained in a number of other policy documents. So it raises a number of challenges. If you look at that cube, if you imagine the red block is where we currently are, in terms of who we're funding, what services we're covering, and how much money we're putting into the pot. If you look along the bottom axis, you look at which is the population that's covered. There's a gap between who we currently cover and who we need to cover, even with the current services that we are offering. If you think about, for example, delivery in a health institution, safe delivery assisted by a health worker, I can tell you that not all people are actually going to a health institution for delivery. A large number in our population, and I'll show you the statistics, are not covered. We still have maybe only 60% or between 60 and 70% delivering at a health facility. So we've got population groups that are not covered by services that we are considering to be essential services. The second on the bottom barrier is on the bottom part of the cube, is what services are we offering? Are we offering everything we should be offering? And I'm going to talk about that because we are quite good at doing infection control, malaria, TB, and even in some of that we're not covering everybody. But what about dealing with diabetes or hypertension or cancers? Are we providing the necessary services for those sorts of areas? Are we dealing with public health effectively? So what package of services are we effectively delivering to make sure we are dealing with the main population health burdens? And then if you look at the vertical column, it's, are we effectively providing financial protection? Are we ensuring that nobody is impoverished? Have we adequately mobilized resources to make sure, and are we delivering it in the right way? So those are the questions. Who's covered? What is covered? Who pays? And are we using the resources effectively? Those are the 4 questions that we have to answer when we are trying to address the extension of universal health coverage. Does that make sense to you? Fairly straightforward. Huh? So when we look at the policy commitments that we've made in Zimbabwe towards this, we've actually been asserting a policy since independence of universal health coverage by calling it by other names: health for all, planning for equity in health, national health strategy, etc. And in fact, Zimbabwe was ahead of the UN declaration. The UN declaration came in 2012. Before it even came in, Zimbabwe, under the Ministry of Health, set up a technical working group in 2011 that started doing technical work in 2012 before the December UN declaration on how are we going to move towards universal health coverage. So Zimbabwe has led ahead of many other countries in thinking about this issue because it has been a long-standing policy commitment. It was also given new momentum because in our constitution, our 2013 constitution, it states that every person shall have a right to basic, accessible and adequate health services, and that the state must put in place measures to ensure it, not necessarily to provide it, but to ensure it. So, it's a good thing we don't have a very litigating kind of community in the country, because there could have been a number of court cases already around the deficits in that constitutional right. So we need to very quickly clarify, what does it mean? The state has the obligation to progressively realize that constitutional duty. What does that mean? What services? For whom? Paid for how? So this is not something we should be sitting back on. We should be actually quite clear. And that means working with the entire community, not just the state in its delivery role, but with the private sector, with the households, etc., etc. And note, by the way, that the state must also take all preventive measures to make sure that people are not exposed to unnecessary and avoidable risks. Water, for example, is a constitutional right. Having access to safe water, having access to safe sanitation, etc., etc. These are matters, by the way, that have been taken to constitutional court in other countries. I think only we've had one constitutional case around health in Zimbabwe so far. So what are the kind of issues that we're having to address? So the first issue is that when we're thinking about universal health coverage, we're not talking about something we're going to achieve in 5 years. This kind of movement forward is something that we're actually looking towards maybe achieving based on the experience of other countries over maybe even a 20, 30-year horizon. Remember, the Sustainable Development Goal talks about 2030, 15 years. But we are even knowing from the experiences of countries like Thailand, Chile, etc., that have made much more progress, that they have indeed taken 20 years to build, to set the framework and build and actually move towards the realization of what they could say is we're getting to what we could consider to be acceptable universal health coverage. A country like England, which adopted a tax-based national health service immediately after World War II, has been using it over 60 years to solve new problems that emerge. So it doesn't mean that you reach the end point. Always there are new developments because of population health burdens and economic context changing. So we're looking at what is the long-term future for Zimbabwe. We're trying to think through this issue so that we don't simply set policies that are reactive for today and then they become the wall that then we can't get over for the long term. We need to think about how we're dealing with today's problems that put us in a good position to deal with the long term. And some of these issues, and this is coming from WHO, and we've just added a bit onto it, is that generally we're going to have more aging people. We're going to have more burdens, more health burdens into the population. But here in Africa, we also have a continued youthful population with all the reproductive health and other associated risks, mortality, maternal health, etc., that are associated with a young population. So we've got a combined population demand on our health services that we need to think about. We are also living in a period where health innovation is going to become probably one of the main zones of innovation globally. We're going to see a lot more health technology coming out, a lot more innovation around vaccines, around bioengineering, about biotechnology, artificial intelligence. People are now 3D printing ears. If you lose your ear, you can put on an artificial 3D printed ear. This is the space of innovation, and it's innovation in health, innovation in the life sciences, innovation in environmental sciences are going to start coming together with informatics. We are now seeing people, I don't know if any of you do it, where people are regulating their own blood pressures and checking their own exercise by having those clip-ons, and your smartphone can tell you whether you did enough exercise in the course of the day, and so on and so forth. We are all being connected in as part of the health community, and this is going to grow. We're seeing growth of telemedicine, etc. So we need to think about that. How are we factoring that in to the way we're thinking about UHC? Climate change is increasingly going to be a phenomenon. We're in the middle of a drought with nutrition problems. So although we are seeing innovation, we are also seeing a growing level of problems associated with the way innovation is taking place that's causing issues for the health sector and natural disasters. Globalization is an increasing an increasingly almost catastrophic phenomenon because of the financial booms, busts, etc. So you've got to think about how we're going to even out our health spending, because we can't have a situation where people are on antiretrovirals today, tomorrow we don't have the money to fund it. Because what happens? They become resistant. Those antiretrovirals no longer function, we've got to find much more expensive medicines. So we can't have uneven financing. We've got to have a fairly even plateau of how we are going to manage health. And we've got to make sure we get the benefit of these resources from globalization. We know that healthcare costs are rising, so we've got to think about how we manage the cost drivers of healthcare. We also know that we are getting a rising level of non-communicable chronic diseases, which is a phenomenon that's already existing in the high-income countries. But here what we have is a double burden. We've got the infectious diseases coexisting with the rise of non-communicable chronic diseases. So we're going to have, for at least the next 30 years, what we're going to call a double burden. So if we think we're having quite a lot of health problems now, we can envisage that this is going to grow, and I'll show you the graph on that. We're also getting much more informed citizens, people who don't just accept, who ask, who want to be part of the process. The question is, how do we work with that? How do we work with a literate population? And then we are getting much more urbanization, people in much more concentrated spaces. And I think you saw from things like the Ebola epidemic, the movement of people is intensified these days. So something that happens in one urban center or in one area of the continent will move very quickly across the continent unless we are ready and able to deal with these kind of concentration factors. So thinking about universal health coverage, we've got to think about it in terms of these emerging challenges so that we design a system that's going to enable us to be resilient to all of these sorts of challenges. So some of the kind of issues that we're talking about in the current situation, okay, that we're factoring those challenges into already, that already exist, is a high level of inequality in access to healthcare. This is from the DHS data, which is population data in Zimbabwe. And you can see, for example, the first graph is from the least well-educated, which is often the poorest, up to the most well-educated, which is often the wealthiest, I mean, in terms of education strata. Those are the mothers. So you can see 30% of mothers with low or no education access a health facility for the delivery of their children, compared to over 90% of mothers with education. This is a massive coverage gap, 60% points difference between the lowest and the highest. And we have some coverage gaps like that in a range of areas. Look at the contraceptive use. We've got coverage gaps. So it starts with adolescents who fall pregnant, who don't get contraception, who don't use the services for antenatal care, who don't use it for delivery, who have children, who then face all kinds of health problems. We have this inequality that gets magnified in our society. And that's a challenge in terms of the who. How do we get the people who are falling out of the services, who are often the poorest, probably the ones with the least education, etc., to be covered? How do we do that? You can't just make the service available. And the problem we're facing is that this is also growing in urban areas. We are discovering that there's actually a rise in urban poverty. So just having urban services there is not solving the problem. Now, if you have people who are not using the services in an urban area, people who live in better protected areas who are using the services are not going to be protected from communicable diseases or infectious diseases that are breeding in other kinds of areas. There is no respect. Viruses have no respect and bacteria have no respect. So we need to make sure that what we do is available to all. The second point is that we are actually not tackling the environments that are generating ill health. Our public health system has declined as our resources have declined, and as people have started to build new areas of investment in the economy that are not taking public health into account. So we have old problems, like a real lack of progress in water and sanitation. Fortunately now there seems to be a bit of a thrust taking place, that the city councils will not connect you unless you put a toilet into your plot and so on and so forth, that the chiefs are moving around with households trying to get every villager to have a toilet, etc. So we're trying, but I think we have a serious problem in terms of the very basics of environments for health. And then add to that, we've got liberalized markets where all kinds of things are crossing our borders, alcohols, foods, fast foods, etc., generating health issues, trade in unhealthy products, cross-border epidemics, unsafe work environments, and so on and so forth, all of which are generating burdens for the health sector. So one of the problems we have is that the health services are treating people and sending them back to the same conditions that make them ill, so they come back into the services again. This is the most ineffective way of structuring a health service. If we don't invest in stopping the causes of these problems, then, and I've seen that, say, Siemens, I think, is now sending out something to tell you that you should join the gym and so on and so forth. That's great. We must get people into lifestyle changes. But we must also look at some of these conditions and get involved in the population conditions that are generating these problems. And make sure that if we are building new roads, let's have bicycle lanes so people can at least ride a bicycle without fearing for their lives and these kind of issues. So that we start to think forward on this sort of thing. So a sustainable UHC approach needs to invest in public health. Then you look at what we think is going to happen with the chronic conditions. And this is a study which we did together with Hutchison and the Ministry of Health, where we projected, based on the WHO projections of the rise in non-communicable diseases in Zimbabwe, and the costs to the households and the costs to the health sector and the costs to the economy of those conditions. And what you can see rising there are the total projected costs if we do not tackle our non-communicable disease epidemic. And I'm calling it an epidemic because it is growing. And what it is that yes, the direct health sector costs are going to rise without question, because we're going to be spending more on people who are falling ill with quite difficult conditions to treat, cardiac conditions, cancers, etc. But the cost to the economy and the households are going to be even greater. Why? Because like HIV, this affects the productive age groups. This takes people who are earners out of the economy and takes skills out of the economy and has quite a high knock-on effect within sectors. The last time I put a figure like this in front of the Reserve Bank, it was around HIV, and it led to the AIDS levy. And I think we are actually moving in a very similar situation unless we start doing something now around preventing this escalation of non-communicable diseases. So yes, we have policies, but we also have challenging conditions. We have challenging macroeconomic conditions, we have challenging lack of formal employment, we have rising costs of medicines and so on. We have, I'm sure you've read that we have an antimicrobial resistance problem globally, where the antibiotics we are using are no longer effective, and we're having to replace them with more expensive ones and so on. So the general environment is quite a challenging one. And we have public health sector funding, which is way below. And then we have a lot of money flowing through the system, but all in bits and pieces, if I can put it that way. That's a chart of our health financing system. So on the one side, you've got the public system, which is funded from the state, from taxes. On the other side, you've got private financing. You have approximately the same amount flowing through the public system for about 80% of the population, 90%, as you have flowing through the private for about 10% of the population. And the two systems don't necessarily talk to each other very well. That's a major issue if we're trying to tackle universal health coverage. Government spending on health as a percentage has fallen and is below the commitment that the heads of state made in Abuja in 2001 of spending at least 15% of the government budget on health. It's now at 8%. It has made us much more dependent on external funds, but the external funds are coming in for very specific disease programs, rather than necessarily for the whole health system funding. Our per capita expenditure on health is way below what it should be, and I'll show you what it should be, but it's way below what actually the rest of the countries in the region are spending on average. We have a rising level of out-of-pocket spending. This is people paying cash for services which they shouldn't be paying cash for. They should actually be getting primary care services free, or they should be getting the basic packages without having to pay cash at point of care. 37% of our health financing is coming from cash payments, which is crazy. You can't fund universal health coverage that way. And then we have a rising level of dependency on external resources. So how are we going to move from that kind of a challenging situation towards universal health coverage? And I'm just going to throw some of the options here. When we talk to stakeholders, and we've had quite a lot of discussion around this, the view has been that we need a domestically led strategy. Yes, we have international agencies, but we need to put in place a domestically led strategy where we all work towards a common goal. We can't have people pulling in different directions. There aren't enough resources for it. So we need to have consensus between public-private actors, between providers, financiers, funders, and users. And we need to have consultation for the buy-in on that. So whatever we do, needs to be driven with leadership from the public sector, but with consultation and dialogue throughout. We need a more holistic approach. We can't have the self-protective approach where I look after my own little scheme and the rest of the country I don't care what happens, because you cannot ring-fence yourself from the wider risk that is brought by that. We need equity. We can't leave behind 40% of the population in any strategies that we come up with. And that means we must reduce the out-of-pocket spending, because that's generating inequity in the system. And then we need public trust. We will never be able to do anything unless we can have accountable, transparent, and non-corrupt systems. So, from other countries, the experience has been that there is no magic bullet. But what have other countries done to make progress? So one thing is that they've taken population approaches. They don't just cover individuals. They look at groups at risk and design their programs, their policies to cover population groups. And they look at the impact for the group as a whole, whether it be young people, whether it be women, whether it be people with chronic conditions, whether it be workers, etc. So they look at populations. They look at barriers in certain groups then to using the systems that they design for populations to make sure that they can use those systems. They reduce out-of-pocket payment and shift it to prepayment, and I'll talk about some of the options on that. They increase risk pooling. You can't have a system where you only cover the better off and leave the worse off on their own. You've got to have a system where you can cross-subsidize risk between those who have less demand and those who have more demand. And I think you know that from insurance principles, but also from those who are rich and those who are poorer. So they look at creating big risk pools that can sustain the demand on the system, but that can also pay for public health, because public health works to deliver to populations, it doesn't deliver to individuals. So we're talking about vaccination and so on. They look at public financing as key, but they also look at strategic purchasing and improving health system efficiency. So in the last few minutes, have I got 2 minutes left? I'm going to race through some of the options that we've done in Zimbabwe around how we move forward. The first thing was to clarify what is the entitlement. Do we even know what services people should be getting? And so what Zimbabwe did was take a very old core services package that the ministry had in 1995 and update it to say, given our current population burdens, this is what we consider our essential health benefit to be. And they costed it $16 per capita for primary care and $74 per capita for hospital care. And that's not that different to costs that have been found elsewhere in the region. So now people should know, even if you're private or you're public or whatever, are you covering that benefit package? They also looked at strengthening primary care. If you look at the results-based financing programs and all the things that have been going on, it's about making sure that when people use the front line of the service, they get effective treatment. So they don't end up using expensive hospitals for things that they should have used at the GP or the primary care level. That's a critical option. They're also looking at how do we invest now in non-communicable diseases. For example, if we vaccinated and the vaccine is available, school children against cervical cancer, we would not have the leading cause of cancer in Zimbabwe, which is cervical cancer. We would get rid of that as a problem. So vaccination is a more effective one, but we don't have the money to do it unless we invest in it. Then thirdly, we look at investment in social roles. Yes, we need a lot of paperwork and efficiency of administration, but we also need to use the asset of a literate population and engage the populations more effectively in healthcare. And then finally, we need to move towards an adequate level of domestic funding. You need to get the Ministry to Finance to understand the risk of not adequately funding the health sector, to move from out-of-pocket to prepayment, and to move from small little risk pools of prepayment into large risk pools of prepayment. And I will say that in a country like ours, to have 30 medical aid schemes is crazy. These are not big enough risk pools to manage the current situation. So we need to think of the transitional arrangements that can move us in the long term towards that. And some of these transitional arrangements could be quite risky. For example, community-based health insurance might look like we're raising a lot of money, but it might segment people into very tiny little pools that will not enable us to move forward. So I'm going to skip some of this and just end up with the opportunities for innovation and learning. There is a lot of work going on at the moment in the ministry on a new health financing policy that is trying to tackle some of these areas. Looking at tax funding options, looking at insurance funding options, looking at the relationship with the private sector funding options and so on. One thing that's clear is that unless we have good information, and I'm saying this to you as actuaries, unless we have good information, we're designing these things on the basis of opinion rather than on the basis of evidence. And when I see some of the evidence that's being brought to the table, it's a bit like the guy trying to drive a car saying, yes it is, no it isn't, yes it is, no it isn't. We really need to have good evidence brought to the table, including from the private sector, on what is going on in these schemes. To be able to think about the relationship between public and private financing. And to think forward, we need people who are going to think about what are we projecting our way to design schemes that are going to solve that. And then very importantly, we need to, because we're going to have multi-morbidity, we need to follow people and not diseases. Think about it, in Netherlands, for example, they bundle payments for risk groups for a range of different conditions, rather than just paying for a condition. Because the same person has cancer, has HIV, has hypertension, but what you're doing is creating a problem that they've got to go to 4 different users to get different services, rather than a comprehensive approach, a one-stop window approach. So we need to think about how we tackle multi-morbidity, mapping the risk groups within our communities, enrolling our populations and knowing who they are, ensuring when they get to a primary care facility they're tackled effectively, making sure our frontline workers have the expertise, and then addressing the cost drivers. So, no magic bullets, but we need policy principles that we're going to implement as a community, collectively. We know the challenges that are coming. We need to act now to address some of them, like the out-of-pocket NCD issues, and then we need to have the good evidence to think forward for the next 20, 30 years to design the next thing. Thank you.
Thank you, Rene. We'll take questions now.
Thank you, Dr. Rene. What a pleasant presentation. I just want to pick your brain on the innovation in the insurance sector has been to introduce micro-insurance products. Within an insurance context, very little underwriting, etc., to increase the risk pool. From what you have said, I can't quite pick whether you would advocate for a similar approach to healthcare, where you have a micro health product or micro health medical aid. It would seem the most efficient, the most effective way from a structural point of view has come from the private sector. And the private sector does not, perhaps, they haven't dedicated enough attention to develop a product that caters for that space that are otherwise currently being catered for by the government. What would be your thinking around how will the private sector resolve that problem?
Okay, are there any more questions? Questions? Okay. Second question there.
Rene, very fascinating presentation. My question is around prospects of a levy of some sort towards preventative care and wellness. Are there any insights from whether or not the AIDS levy has achieved the desired outcome when you set off with that? What are the disparities between what was achieved and what's actually been, what was projected and what's actually been achieved, and what are the prospects for a wellness type of thing?
Question. Most universal healthcare conversations have to do with providing health services to people, but to incentivize private financing into it. Do you not think that that data can also be corroborated with what you get the return in investing, which data will probably include extended lifespans of people, what healthier people contribute to the economy as a whole, so that it gives private buy-in that by investing in them, you also get active labor.
The first question, and let me just go back to this because I raised it a little bit, but just to make it very clear. And I'm saying this information on the basis of work that's been done in many, many countries internationally, although there have been a few studies done in Zimbabwe. One was presented at the research forum we had last year on these micro-insurances in the health sector. That essentially to fund the kind of population level coverage that you need for universal health coverage, the World Health Organization is very clear that the main tool you have is either taxes or mandatory health insurance. I need to be clear about that. That you need to have population level insurance coverage or population level coverage through taxes in order to fund it. And no country has successfully done it without that. So whatever you're funding, that is a basic platform. In Zimbabwe, we're tax funding. And so one of our questions first is, can we A, use our taxes more efficiently? And I'll come on to your question about the AIDS levy. But also, are there other tax latitudes that we should be looking at? And Zimbabwe has looked at tobacco taxes, cell phone taxes, earmarking a portion of VAT, which is what they do in Ghana, all of which could generate predictable resources for the health sector. The point I want to make about that is that unless we have these level of predictable resources, we don't have a basis for what we call strategic purchasing. Right now, if you tell a local authority not to charge fees, they will not listen to you because they're not giving them predictable financing to deliver the package. So we need to have that predictability, which comes through these quite large funds. When you look at these other funds, private voluntary insurance becomes more equitable when the risk pools are larger. The larger the risk pool, the more equitable the fund, the more possibility of having risk and income plus subsidies in the pool, the more possibility it has of expanding the benefits it covers because it can actually take on the kind of risks that are included in covering benefits and so on. The more administratively efficient it becomes. The problem with the community-based insurance is that what we found from other on health is that the risk pools are tiny, the contributions relative to benefits are quite exorbitant for the people. The possibility of having income and risk cross subsidies are very low. They're often concentrated within a particularly more homogeneous community rather than across different groups. They're not that portable. They don't necessarily move from one area to another, so we have quite a mobile population. We don't have people just sitting in one place using the same service, etc. And they tend not to be able to fund, they tend not to be enough to fund the essential health benefit, which if you recall was $16 per capita, even at the primary care level. And where the financial protection really kicks in is around hospital services, is around people having to use the hospital because they didn't have a decent primary care service. So we are saying community funding, we do have it in Zimbabwe. We have a lot of places where people are pooling funding. It's very good to add value to your service, to build a fence, to make sure that your drugs don't get stolen, to make sure your health worker has a house to live in, to build a water, these things are going on in Zimbabwe and they're doing incredibly good work for supporting the health system. But for funding a basic health system, they have not been successful. And at the same point about the private medical aid, as long as it's in tiny risk pools, we have a problem with private medical aid. It's very administratively inefficient and very inequitable. So when we're looking at the relationship between the private and the public, we need to have a private that is talking to the public in a more robust way. For example, I know in South Africa there are laws that require private insurance to cover a certain benefit package as a core. We don't have that in Zimbabwe. But every private insurer should cover the essential health benefit. Otherwise, we're having two different health systems in the country. I should know whether I use a private or a public, that certain things are going to be covered, including contraceptions, vaccinations, and all the things that will stop me from getting ill. I don't know if that answers your question. And I mean, there's a lot more information we can give on that in terms of supporting that. The AIDS levy has played a number of quite important roles. What it did was it gave Zimbabwe a level of domestic financing to smooth out all the international funding that was coming in. And I think we've had quite a rocky period with international funding. So one of the most important things that the AIDS levy has done it's enabled us to continue to treat people for HIV at times when international funders have pulled out of that funding. We have avoided a very dangerous possibility of resistance to HIV medicines because of the AIDS levy fund. I want to put that on the table. And so we have to think not only in terms of the number of people treated, or the number of preventions, but also the long-term ability to ensure a particular disease program. Zimbabwe reduced HIV. It was one of the countries to turn around and reduce its HIV epidemic more quickly than others in the region. But I'm not sure I would attribute that to the AIDS levy. I would attribute that to the education levels of the population and the willingness of youth to change. It was very much generated in the younger population, taking on measures that were preventive. The AIDS levy may have contributed to that in its preventive work, but I don't think it was the sole contributing factor. And it's one of the reasons I say we should be capitalizing on our educated population much more than we have in the past, because that's a huge asset that Zimbabwe has for health. But I would say that there is a discussion now to say that the positive experience and the way people are viewing the National AIDS Council as being a better way of managing money in a more semi-autonomous fund that can report to Parliament, that can produce audited accounts, etc., is a lesson that we are raising around how we're going to finance our non-communicable diseases. And some of the extra funding that we're thinking about, if we were to earmark a portion of that, or if we were to use these earmarked portions of alcohol or cigarette levies or whatever, we're saying maybe we should be managing it in the same way, in a semi-autonomous fund, so that we can start bringing in these first-order prevention measures, screening measures, etc., into the country now, before we have the epidemic. Have I answered your question? And I'd be interested to know whether you support that, whether you think that's a good idea. But that generally is what's come from stakeholders. And then, and by the way, one of the things we are saying about health financing is that although the economy is not in a great state at the moment, we need to look at where its growth is going to be, so that health grows with the growth. And you know, for example, the AIDS levy, we never had it. The mining sector was exempt up until 2014, when we discovered it was exempt, and we said, no, that's the only place where money is being earned, bring them on. So the levy was lifted in the mining sector, so we were able to carry on buying things. So we've got to be a bit clever about where we are applying these things and not putting them on the poorest for financial protection. And then the question about health services, the last gentleman asked, is that actually universal health coverage is as much about financing as it is about health services, and it's as much about projecting forward the challenge as it is about providing the service for today. And I think that if I sort of understand correctly, that it's going to imply some kind of redesign in thinking about our health services. This, by the way, is going on in many countries globally, where people are redesigning services to think about using their frontline services more effectively, taking things that were done at hospitals and doing them at primary care level, using technology advances to take things that were done inside the service into the community, etc., etc. So universal health coverage is as much about redesign of the service as it is about then financing and incentivizing that redesign. And we can't think of it as the health sector only. Actually, the Minister of Health, the previous Minister of Health said to me one day, every minister in government is a Minister of Health. Because if I'm designing the urban transport system, I'm actually either generating risks for health or I'm solving risks for health. If I'm building the water supply system, I'm either going to make it possible or I'm not. If I'm distributing land, at the moment we have a problem where people are living on land without adequate infrastructure. So these are, every single minister is doing something that is either generating health issues or is creating less burdens for health. So we are actually talking about health in all policies, not just the delivery of services. And there's a lot of things about how we are incentivizing that. What tax breaks do we give for when you have less health, when you have more health promoting strategies for your business and things like that? You know, so there is a discussion on a new public health, on amending the public health law to bring it up to date, to take on some of these new perspectives and integrate health, so that we're not trying to take the problem, we're trying to stop the problems. And this is something which we've learned from global experience. We don't need to reinvent the wheel in Zimbabwe. We have a lot of experience to do it on. And actually, to be honest, we're quite well placed to do it because we are sitting at quite a low level. We don't have to be the, you know, you heard about China growing its economy but creating such an air pollution problem that when they had the Beijing Olympics or whatever, they had to stop all industry and all transport in order to get rid of the air pollution. We don't need to follow that path. We could actually look at the technologies we bring in, and we could work with our own domestic producers to create health promoting. We could be the green health promoting economy of the region that others are learning from. And we've done that in the past. People are using our Blair toilets all over the continent. We export health promoting technology. It's because we have an educated population. It's a potential niche area for this country.
Right. Any more presentations?